Hello everyone, I'm Dr. Darsh Shah.
And I'm Dr. Altamash Raja.
And welcome to Medicine Redefined,
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare. Hi everyone, I had the pleasure of sitting down with Dr. Raj Dedhia. Raj began his medical journey at Northwestern University, where he obtained his MD. He then went on to the University of Pittsburgh Medical Center, where he trained in residency for ENT, head and neck surgery. Afterwards, he decided he wanted to become a sleep medicine doctor, so he obtained a fellowship in sleep medicine at the University of Washington. Soon thereafter, he started working at Emory University in Atlanta. But now he's at the University of Pennsylvania, where he serves as the director for the sleep surgery division. Currently, he spends half of his time doing research, looking at different therapies for obstructive sleep apnea, as well as looking at patient outcomes. He's got a ton of papers under his name, so just a quick Google search and you'll get flooded with his name and results. The other half of his time, he's spending either doing surgery or acting as a clinician. So to him, he essentially has the trifecta, which he will talk about later in the episode. But we start off talking about all things sleep apnea: the who, the what, the where, the when, and the why. Who really becomes affected by sleep apnea? Is it only adults, or can children as well? How does sleep apnea happen? What are the therapies for it? What should clinicians know about it? What should patients know about it? How do we know when we need to get a sleep study? What actually even goes into a sleep study? So don't worry, I know it seems like a lot, but Raj has a great way of breaking down everything. In the last half of this episode, we touch on the current state of research, especially for pre-med and med students. Right now, there seems to be something in the air that talks about how in order to be competitive in this field, you need to do research, even if your heart and soul is not really into it. And that's a shame. But Raj and I have a great discussion on it, and we talk about ways that maybe this really doesn't have to be an issue. Anyways, you guys will hear a bunch of apps, you'll hear about research articles, everything should be linked in the show notes, so be sure to check those out. I hope you enjoy this episode. All right, what's up, listeners, Medicine Redefiners? We've got sleep extraordinaire, Dr. Raj Dedhia, in the studio, virtual studio that is, with us today. Raj, thank you so much for joining the podcast. So, rightfully so, sleep has finally gotten the attention it's needed, right? I mean, Matthew Walker has come out with the book, Why We Sleep, so that's kind of put it on the map. And even on this podcast, we've talked about it a couple times. One, we talked about sleep in terms of what it's like to be an insomniac, sleep deprivation, sleep hygiene. And then we also talked about it in terms of pain and sleep and kind of how those two are related. But with you, you are a sleep apnea specialist, so to speak, and you've done sleep medicine. Now, I think people know that sleep medicine is a field, but to get there is a different story. And I don't think a lot of people, even in medicine, quite understand how one becomes a sleep medicine doctor. Take us through your journey a little bit, maybe, starting from med school to where you ended up and kind of what got you interested in doing sleep.
Thanks for that question, Darsh. My path was a little atypical. I was an ENT surgeon in training in Pittsburgh, and I happened to pair with a guy who did a sleep fellowship out of ENT, and I thought, oh man, even a surgeon can do a sleep medicine fellowship, which is true. So I was an ENT, spent time with this young doctor, and I realized that he was helping people breathe while they sleep, which seems like a God-given right. And then to say that you can't do that, and it wakes you up every 1 minute or 2 minutes, I cannot imagine what you feel like in the morning. And then on top of that, what you hear with the spouses are like, yeah, I feel like my husband is dying every night. He's like, choking and gasping, and the partners often don't sleep very well. So really kind of, as a surgical resident, being on call every few nights and waking up in the night, I mean, I know what it's like if I don't sleep well, being disturbed. And I could actually empathize with the patients, which as you go through training, when you find something like that, I think that really is helpful as a trainee to say, you know what, I think I can do this because I get it. And so I think I got it. And then at that point, I thought, okay, I want to do a sleep medicine fellowship. And you're asking, how can you get there? Even medicine, it's not really clear. There are, I think, 7 specialties that are allowed to sit for or to be part of a sleep medicine fellowship.
Oh, wow. I didn't know that.
Yeah. So you have, pediatrics, internal medicine, psychiatry, And then within internal medicine, pulmonary is a common one, but even neurology, anesthesia. So these are different pathways to get into sleep medicine, and then of course ENT surgery. So that's again, uh, I was one of two ENT residents to do a sleep medicine fellowship the next year. So it's a very small, still pretty small field, but that's my journey.
Yeah, so you can relate to it. Both of us can relate to it from a medical trainee perspective, right? I was just on call this weekend, probably woken up 5, 6 times, exhausted this morning. So we can only imagine what patients go through who have sleep apnea.
Mhm.
What about from an ENT perspective? Where did you see the connection between ENT and sleep apnea directly?
Sleep apnea is a problem of the throat, plain and simple. Obstructive sleep apnea is obstruction. I'll simulate. That's snoring. And then you have a gasp, and then the patient breaks the gasp. But that's the pharynx, whether that's the palate, the tongue base, sidewalls, that's collapsing. And so nobody knows the anatomy better than an ENT. And I think that was what I
Mm,
realized. There was a need, right? We usually flock to a need. I flocked to
right.
this need, saying that, hey, there are very few ENTs that are treating sleep apnea, other than basic surgeries, but nobody really understands the physiology behind it. I mean, few people do, including my mentor, and that's what's allowed me to, take that and run with it for the last 8 years.
Awesome. So let's actually break down sleep apnea. So you said it's an obstruction. Can you break that down further? What are the patients experiencing, to the T, if you had to explain this to a family member?
Yeah, no, this is a common part of my clinic is to explain to people what's going on. So sleep apnea, plain and simple, is repetitive obstruction of the throat during sleep. And most of us won't. Let's say we don't have sleep apnea. When you're asleep, you have muscles in place that are counteracting the negative pressure when you breathe in. When think about it, your diaphragm descends, you're filling up your lungs, you have negative intrathoracic pressure. That negative pressure is then, of course, is going to be applied to the throat to help pull air in. And if you don't have counteracting dilator muscles, then you're going to collapse and you're going to snore essentially. So if there's some problem with, usually it's anatomy, so tonsils, small jaws, something that's going to limit the airway, that's not enough to counteract that negative pressure, then you have collapse. Conversely, Dersh, if you have a woman, for example, who's postmenopausal, menopause, we have a withdrawal of progesterone and estrogen, and progesterone is really important to maintain muscle tone. And women, you'll maybe in PM&R, you may see this in your own world, where women, perhaps especially after that age or after that part of the phase in their life, will suffer in different ways with muscle tone loss, even bone wasting. But for me, it's muscle tone. And so we see my clinic is a lot of women over 50, over 60 that are thin, that were didn't snore much beforehand, and now they've got bona fide sleep apnea. So it's a good example where in older patients we see more of this muscle tone issue, and in younger patients, the kids, for example, big tonsils, it's more of an anatomic issue. But you kind of need that two-hit hypothesis to hold true, where you have an anatomic insult and a neuromuscular loss, and that is when you in the throat it causes the obstruction.
That's interesting. So I think most people, when they think about the typical patient with sleep apnea, they're thinking like, the thick necks, the
Yeah.
football players with absolutely thick necks. So when they're sleeping, it's like, oh, that makes sense. It's going to obstruct because they have so much muscle. But you're telling me here, you can even have thin women, right? Once they hit the menopause age, or even young kids with big tonsils.
Yeah.
So have we been seeing an increase in sleep apnea throughout the years, or is it more of just the awareness of it kind of coming through and showing light on it?
It's both. Yeah, it's absolutely both. There's a really nice um, series of literature that describes, this is fascinating, that the human jaws are shrinking. I don't know if you know this, Dersh, but the
Mm,
human jaws are
yeah.
shrinking since the
James
industrial.
Nestor.
James Nestor, breath, you got it. Yeah,
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 breath,
yeah.
man.
He's James Nestor. I think yeah, we had him on our at Penn. We had him in our department grand rounds. We got a chance to talk to him and spend time with him. But that book touches on this idea. Since the Industrial Revolution, 1800, human jaws are shrinking for several reasons. But the point is, if that's true, well, then of course, if your bony cage for breathing is shrinking, well, then obstruction is more likely. So I think we are seeing. I mean, it's why you see how many kids have orthodontics now. I mean, that's almost like the norm. Well, that I'm at Penn at the Penn Museum, just down the street from the hospital. There are these ancient skull collections, and if you ever walk through them, any skull before 1800 has perfectly straight teeth. I mean, I'll say that statement, and they don't have any sign of crowding of the teeth. I mean, now it is really the norm that kids have crowded mouths, and so there's something to that. I mean, I think it's to me it's pretty clear, but the point is that yeah, so that there's more of that. There's also more obesity. So now you're throwing a smaller bony cage with more subcutaneous fat. Well, it's a recipe for this now. Prevalence is about 10-20% of people have sleep apnea. That's a high number in the U.S. And then you sit on top of that is awareness, like you said. Sleep. The American Academy of Sleep Medicine was founded in 1980. I should say CPAP and sleep apnea was discovered in 1976. It's pretty young, right? On the spectrum of what you've learned about with insulin or even penicillins. I mean, this is 45 years old, and so before that, who knew? And I'm sure I have uncles in India who just snore, and you say, oh, he's a deep sleeper. God bless him.
Right.
Like he must be really tired. Well, he's really tired all the time. He's always sleeping. I don't think it's
Exactly.
a good thing, but it's a cultural acceptance of that now I think has changed.
So yeah, speaking on the symptoms, right? You touched on one there about being tired all the time and snoring, right? I think those are the two major complaints that I typically hear in the hospital. That I was like, okay, now we probably need to think sleep apnea. How specific or sensitive are those symptoms when it actually comes to sleep apnea, or should we be looking for other markers?
Yeah, yeah. Thanks. These are great. There's snoring is a common sort of symptom, or I should say, bed partner complaint of sleep apnea, and it's very difficult to have sleep apnea without snoring. You can have snoring without sleep apnea. That's sort of we think of snoring as sort of the precursor to sleep apnea. If you just have snoring, okay, usually snoring is accompanied by choking and gasping, and that's sleep apnea. That I would call that a nocturnal, marker. But daytime symptoms, sleepiness is a big one. But only about a third or 40% of people have sleepiness with sleep apnea. About a third of people are actually not sleepy. They're just, I'll use the word pissy. I mean, they're irritated.
Mm,
They're
yeah,
irritable. That's how I am when I don't sleep. When the kids are
right.
little. I mean, so I think that's the different expression or phenotype of the disease. And then the third people actually have no symptoms. I mean, they come in because their cardiologist sent them because they said, you have, or their wife sent them, but they're like, Dr. Dady, I don't know why I'm here. I don't have a problem. I feel fine. I work at 9 to 5. I don't, you know. So that's what we see is a sort of cluster of three groups: the sleepy group, the sort of the irritable group, and the asymptomatic group.
What are the downstream effects of sleep apnea, right? So you're talking about the people who may not have any sort of symptoms, but yet a different provider is going to be sending them over to you because they're probably seeing something. What are
Yeah.
those things?
Yeah, so as doctors, we have to think about the medical ramifications, and the biggest one is cardiovascular.
Hmm.
Untreated sleep apnea, let's call it moderate to severe disease, doubles your risk of high blood pressure, uh, triples your risk of diabetes, increases your risk of atrial fibrillation by sixfold, uh, death by about twofold. So these are like 2 to 6 odd ratios for different, bad things. Doesn't mean you're going to get it, of course. As these are associations, not causation. But the idea is that I can tell a patient that if you don't treat this, you're going to double your risk of developing these things. So those are the things that we think about. Now, you can go beyond that, Dirge, and think about some of the neurocognitive effects. We think about dementia has been
Hmm.
associated with sleep apnea. Uh, but I would sort of stick to cardiovascular and neurovascular things that happen with this.
It's interesting. Yeah. I mean, obviously in rehab, we were talking about this offline yesterday, is that I see so many patients come in with sleep apnea, so many. And it makes sense, right? A lot of these people have cardiovascular issues. They're going through cardiac rehab, pulmonary rehab. And then you keep going down the stream, and then you say, okay, they're going to need a surgery. They're at increased risk of fall, et cetera, right? You see that morbidity and mortality kind of go up. But one of the biggest things with sleep apnea that I've seen is that if they don't have their CPAP or they're not actually getting adequate rest, I mean, man, that is really taking a toll into their 3 hours of therapy that they really need to do with us. So, just for the listeners to kind of just grasp that, hey, this one thing about sleep and having this apnea can definitely have these downstream effects of not only your day to day, but also kind of thinking long term.
Yeah, and with that, there's just like, one of the common sort of anecdotes is a patient gets treated for sleep apnea, and they say, doc, I lost 20 pounds afterwards. I said, well, why? In fact, CPAP alone makes you gain weight because you're not struggling to breathe at night, so you stop burning calories of
Hmm.
choking, believe it or not. But what happens
Oh,
is
wow.
people say, I'm rested, and I make better decisions. which I think we all can relate to, right, Dersh? If you're sleep deprived and you're
Yeah.
up late on call or sitting for exam, I mean, you eat the Doritos and drink the Coke, and you wouldn't do that otherwise, right? Or you skip
Right.
the gym, or what I'm saying. You don't feel like yourself, but once you have that quality of sleep, it's amazing what you can do. So I tell patients, I say, I'm going to help you get sleep quality. I'm not going to make you lose weight per se, but I'm giving you
Right.
the tools and hopefully the state of mind to make those good decisions. And that's what you're saying. When it comes to rehab, they're pooped after 1 hour because they don't have it in them. They don't, they choose or they can't do it. But I think you give them that fuel to carry on with their day.
Yeah. So, quick tip: if you're trying to lose weight, sleep apnea is not the way to do it, at least, or not being compliant
Yeah,
with your
it's
CPAP.
CPAP alone will actually make you get fatter. So don't do that. But again, yeah,
Wow.
I tell them, use that energy to make the right decisions. Be all right.
Gotcha. So, okay, let's talk about the normal patient out there. They're having some of these snoring, maybe. Their partner sees it, they're getting tired. When do you recommend, let's say our listeners, somebody's out there, they're older, when should they get checked out?
So um, most sleep disorders are defined in our manual as having a functional impairment. So something that you feel as a patient is affecting your daily life at least 3 times a week. These are some of our definitions have include verbiage like that. So that's what I tell people. If something is bothering you more than a few times a week, like if you feel tired, not once a week, but a few couple times a week, and it's a chronic thing, then talk to your PCP about it. And usually, if it's for sleep apnea specifically, there, so we're talking about things like snoring, as you mentioned, and sleepiness, and some of the usual constellation of symptoms. But yeah, typically snoring is going to be there with this, and so having a bed partner or an apps are out there to measure snoring. But I think snoring and some degree of fatigue, that's enough to trigger a referral and likely a sleep study.
Yeah. Speaking of apps, real quick, are there any apps that you recommend that, you've seen people use over time that are pretty reliable in terms of seeing if they're snoring
Yeah,
or not?
yeah, and it's before Apple Watches and this whole flurry of activity and
Yeah, true.
wearables. I mean, right? Because I haven't kept up
It's
with
huge. Yeah.
these things. Yeah, I mean, there are all kinds of. I mean, I get all kinds of download in clinic with patients showing me, this and that, and, I think what's been really pretty basic apps called Snore Lab. Snore Lab. It measures your
Hmm.
snoring at night, so it's just like a microphone
Okay.
from your phone, and
Yeah.
it has got a nice algorithm and has a nice I would say format, so you can look at your
Okay.
decibels on average. You can actually scroll and hear your snoring when it gets to the loud peaks, and so people bring those samples in, which are pretty helpful. So that's one that we use to monitor treatment. So after treatment, snoring should go down, and patients say, you know what, hey, my number went from 50 to 30 or 50 to 10. Like, okay. So if they don't have a bed partner, which bed partner sleeping, it's not their job to monitor your snoring. So
Yeah.
it kind of
Right.
unburdens the bed partner from being that person. So that's, yeah, Snore Lab is a $5 app. I think it works pretty well.
Right. Okay, cool. I remember I was using Sleep Cycle before this whole
Mm,
launch of wearables came on. I don't know if that's still
right.
around.
It's still around. Yeah,
Okay.
people come and still using that and say that helps them, avoid a REM cycle, wake up. I mean, I think
Yeah.
that stuff's pretty good. I mean, it's okay. It depends on you putting it properly in the mattress and
Yeah.
other things. But yeah, those are the two that have been around historically, actually, Snore Lab and Sleep
Sure.
Cycle.
Okay, cool. And I know nowadays, if people want to upgrade their data, you can do Whoop. There's Aura Ring. 8 Sleep is something I use for temperature
Mm,
regulation, which has been pretty cool too. So there's definitely a plethora out there if people just kind of take a look and see how they want to track their sleep. Awesome. So let's transition kind of a patient now in the hospital, right? Because this is, my bread and butter. Patients come from the hospital, coming into the PM&R inpatient and coming over with sleep apnea. So a lot of the times, what I see is patients are desatting overnight. Is that something you would typically see in sleep apnea? And by
mm.
desatting to the listeners, meaning their oxygen saturation goes down, into the 80s, let's say.
Yeah. Yeah, Dersh, I think really a pathognomonic sign for sleep apnea is what we call sawtooth desaturations. So if you look at a saturation profile, look at it, there's a desaturation followed by rapid resaturation, right? And that's an event. So if I'm going to simulate, I know for your listeners, maybe the auditory is useful or maybe it's foolish, but if I'm snoring and I stop breathing, and that's the throat closing. It's a 10-second event by definition for sleep apnea. So if you count right now, that is the shortest event of sleep apnea. Now imagine that goes on for 60 seconds in some patients. I mean, and you're the bed partner, right? Imagine, your wife's doing that. You think, oh my gosh, what the heck, And you're a little bit concerned they're not going to breathe again because their chest is moving. It's a violent. The chest is moving, the belly's moving, but there's no airflow exchange, right? Because it's paradoxing of the thoracoabdominal cage. I mean, your diaphragm is descending, but your chest is sinking in because there's no airflow coming in. So you're seeing this person sort of asphyxiate in front of you, and then all of a sudden they gasp, and then it's like, okay, well, what just happened? Well, what happened is what you said. The oxygen is not going anywhere, so they desaturate. Then they have that recovery breath, and then about 20 seconds after that, they resaturate. That's a lung finger circulation time. They resaturate. So that ping ponging is pathognomonic for sleep apnea. I'm saying that because in your hands and your sphere, you might see something else like a COPD type picture, or where we call it hypoventilation, where their sats are just 82 the whole night, or like 85 the whole night. That's not sleep apnea. That's usually a primary or secondary lung disorder. So I'm differentiating that from, just to say that if oxygen goes down and it comes back up repetitively over the night, you have obstructive or central sleep apnea.
So does it make sense to give oxygen to these patients when you know there's going to be a resaturation event coming?
Oxygen. There's a really nice study, New England Journal of Medicine, 2014, looking at CPAP versus oxygen for sleep apnea, and their primary outcome was 24-hour blood pressure. So, as I told you, blood pressure goes up. If you think about it, when you asphyxiate and then you are relieved of that obstruction, you end up causing an adrenaline surge, right? It's like if you were choking and I choked you, then you let go. So every time that happens, you spike your adrenaline and you spike your blood pressure on every one of those events. If I had an arterial line in your, let's say your radial artery, you would see that spike every time you took that first recovery breath. So that's we think, is one of the two mechanisms why blood pressure is increased in sleep apnea, is that you have these adrenaline rushes. The other actually is the oxygen. When the oxygen drops and it comes back up, you release free radical species. You know this from some of your work on, oxidative stress and inflammation. So you end up creating these free radicals, and that causes vascular remodeling. So the blood vessels become hardened and stiffened. And so you can imagine then that that combination of oxygen fluctuations, with the combination of the adrenaline, is why we see blood pressure rises. So in that paper by Dan Gottlieb and others in 2014, CPAP reduced blood pressure, oxygen did nothing to blood pressure in sleep apnea. And what that tells us is that the oxygen itself is sort of like, just putting a band-aid on it, because you're not actually helping with the obstructions, right? You're putting oxygen to help your measurement of oxygen improve, but you haven't treated the underlying problem, which is the throat is closing every minute or two, right? So you're helping the oxygen, but you're not helping the underlying, in my mind, the problem. And that's where CPAP actually is a pneumatic stent. It blows air through the obstruction, keeps it, stabilized the whole night, because there's, air passing through that compromised segment. So the answer to your question, yeah, oxygen is okay. I mean, it might placate the nurses because they don't have the alarms triggering so often, and it might make us feel a little bit better because the oxygen's better. The other challenge in your patients especially with brain injury, is that they often have, if you do that, their CO2 levels are going to rise. So imagine this. So if I just give you oxygen, right, and I might be blunting your ventilatory drive, and now your CO2 is going to build up. We don't measure CO2. I mean, I don't think you do it in the rehab floors, customarily. So we're not measuring end-tidal CO2. So you don't know if the CO2 goes from 40 to 50 to 60, and now you're talking about getting CO2 comatose, and now you have a problem, especially in the light of sleep apnea. So I would just be very careful, especially in the inpatient setting, in what you do. If you slap oxygen on there, you want to make sure they're not getting a CO2 coma. And so that's where it just has to have to be careful with that. Yeah,
No, it's a very good point. I mean, we also, thinking about oxycodone, benzos that we're putting on these patients as well. Just a lot of them
exactly.
come with anxiety. A lot of them with so
Mm.
much pain. Also just slowing down that ventilatory drive. So, no, that's really good to know. And again, I think this is such a misconception out there. Apart from your world, like the rest of
Yeah.
us over here are thinking, oh man, there must be a DSAT. We have to put the oxygen. And over at Hershey, we call it the oxygen fairy. But I think one of the biggest points is oxygen isn't always just a treatment. It's a medicine, right? And it can also have bad consequences by just giving someone those 2, 3, 4 liters. Even though you think it's natural, it's what we breathe, right? So important to understand.
Yeah,
but it's not always the case. Yeah.
I think your point about if they're on, and let's say they're on narcotics or benzos, I'm not sure what your patients are getting, right? And they have,
Yeah.
God forbid, a history of brain injury, and now they have sleep apnea, which
Hmm.
is not uncommon in that scenario. Um, you're right. I mean, that's a recipe for a problem, especially if you're not monitoring CO2. So what happens with CPAP alternatively, right? CPAP is able to not just oxygenate because it fills the alveoli and it pressurizes the chest, but it also ventilates. So you're getting rid of the CO2. There's an escape valve for CO2, so you're able to actually ventilate the patient, and that's why it's such a good treatment in that situation. I mean, but one of the challenges in Dershowitz, and we can get this later on, is that CPAP is the compliance is poor. 50% of people don't use CPAP long term, right? So yeah, you got a good treatment, but it's not very effective. It's more efficacious in that controlled setting. So maybe you can get them to use it in the hospital, maybe you can't. And then what do you do, right? And that's maybe what you often resort to doing something like temporizing, like oxygen.
Absolutely. Yep, that's exactly what it is. So it really just depends on the supply. If we have the CPAP, great. Otherwise, we ask them to bring it from home, or else, hey, we're going to be putting that oxygen on.
Mhm.
So, one of the things I want to touch on that I think a lot of people don't understand is what actually goes into a sleep study. So typically in the inpatient side, let's say internal medicine, before they get discharged, we say, hey, we want to get you outpatient to do the sleep apnea, like sleep study and stuff, and make sure you have it. So when they actually go and when they actually return to do that study, what are we looking for? What is it? A overnight test? Is it at a home test? Do they sleep in the sleep lab? What exactly goes on?
Yeah. So it's two main types. There's in lab, called polysomnogram, or a second type is called an outpatient home sleep apnea test. So either you do it in the lab with a bunch of wires I'll talk about, or you do it at home with minimal sort of equipment. Um, there are different indications. If you have a patient that you're worried about, for example, CO2, hypercarbia, increased CO2 because they have a history of hypoventilation. If you're worried about somebody that's going to have limb movement disorders, things that are not just bread and butter sleep apnea, seizures, for example, then you want to get them into the lab with a full hookup. That's typically what you think about that. Home sleep apnea tests are just what I said. They're sleep apnea studies. So if you're just looking at sleep apnea and somebody has a reasonably high pretest probability of having it, home sleep apnea tests are just fine. So again, in lab study, you come to a lab. It's quite an experience for the patient because they come to some foreign lab. I mean, usually in the basement of a hospital or in some kind of funny place, right?
Yeah,
There's no
yeah.
windows, but by design, they come in, they get hooked up with a full EEG. I mean, this is 12 lead EEG. Got the goo in your scalp that comes off like for 5 days later. You've got electrodes, so that's EEG. You've got EOG, monitoring it's an electrooculogram, so rapid eye movement,
Okay.
REM sleep.
Yeah.
We are able to detect that based on the eye movement. So we have these EEG pads here for the eyes. We have chin EMGs in REM sleep is also when you have paralysis. So you look at how the chin muscle activity drops out during REM. So this between the chin and the eyes, we can detect REM pretty well because the eyes are going crazy and the chin is totally silent. That's a very unique, sleep stage we have.
Hmm.
So we have, you have electrodes here. You've got under your nose a nasal flow, in your mouth an oral flow. You have a chest belt, abdominal belt. Yeah, I'm not done. And you have on your legs, you've got leg EMGs to look for limb movements. And this is not a wireless technology. So these are
Yeah.
all wires, and all these wires have to go to an input box next to the bed. So, it's like Frankenstein. I say it's like you're
It's like
hooked
a
up to all
mummy.
these
Yeah, you
things.
just
Yeah, and you see like kind of like sleeping like this. If you move around, things come up. So it hasn't changed in 40 years. This honestly, the sleep lab, it really hasn't changed much. And so that's what people do. They come in, they do this, and but we get great data, Dersh. I mean, I love reading these studies. I read probably 5, 6 studies a week, and it's great because I have all my leads. I'm looking at the monitor. I've got all the leads. And people say, "Well, am I going to sleep, doc?" And usually they sleep at least 2 to 4 hours, usually 4 or 5 hours. So we get enough sleep to know what's going on. And it's obviously
yeah.
very comprehensive evaluation. But that's sort of that one type. That's an in-lab sleep test, insurance pending, clinical indication pending. That's what that is. A home sleep apnea test is relatively speaking a piece of cake. The typical one is there's something around your nose, around your ears, like a cannula to measure your airflow.
Hmm.
You have an effort belt around your chest, and you have an oximeter on your finger. That's it. and we'll hook up to a device, and you sleep, and
Gotcha.
we can look at your oxygen, look at your airflow, we look at your effort, and that's really things that we need to look at. And I can pretty well look at your sleep apnea severity based on that.
Okay. Pretty pretty simple, at least for the home stuff. I mean,
Well, yeah, and
seems pretty intimidating going in.
it is for the in-lab test, and I think the future though really is going to be wearables. As wearables become validated in our world, I mean, think about it. Do I want a one night test or a 30-night test from your Apple
Yeah,
Watch? Right? I mean,
exactly. Yeah.
right, you'd much rather. There's a lot of night to night variability that's well understood in sleep apnea. So you may have a number of sleep apnea number of 5 tonight and 16 tomorrow, and that ends up really dictating different treatment paths. But that's because it's just the one night you're on your back, one night you're on your side. So if I get 30 nights of you, boy, I feel pretty confident that, hey, I've really got this guy characterized. And so I think that's the future, is having wearables that are FDA cleared, approved for our use, so I think that's going to be really, for me, really exciting to have that level of data.
Absolutely. I think wearables is such a cool topic. We actually had a cardiologist come on here, a cardiology fellow, talk about wearables and Whoop especially, because I
Hmm.
mean, you can talk about anything, cardiovascular to sleep to rehab to pulmonary. I mean, it just goes on and on about what we can do with wearables. So it's definitely a super fascinating technology. And I think within the next 5-10 years,
Hmm.
it's just so rapidly moving. I mean, it's insane. Even Apple Watch is telling you your stride length now.
I saw the commercial
It's
for
like,
that.
yeah, it's not even hooked up to your leg. I mean, that's pretty impressive. So, um,
Yeah.
okay, so let's say the patient is diagnosed with sleep apnea. We're now starting to think about treatment. In your mind, when you talk to that patient, are we thinking short term, long term? Where does your head kind of go whenever you're kind of discussing with the patient?
Um, Long term, right? I mean, like as doctors, you want an all night, every night treatment. I mean, that's my adage, right? All night, every night. So if you tell me I use it for the first 3 hours of the night, the CPAP, and I rip it off in the middle of the night, well, you've now basically let yourself succumb to REM sleep. And REM sleep, by the way, which happens in the second half of the night, is the most sleep apnea prone because you have muscle paralysis, right? So your throat muscles are essentially paralyzed and you're relying on other muscles to help you breathe. So sleep apnea traditionally is worse during REM sleep, which is the last couple hours of sleep. So you have to have that protection. So we tell patients again, it has to be something that you're going to use all night, and of course every night. You don't want to miss a night. That's not the point. So it's a long term play, and you know, we're going to stick with adults here. Talk about adults. In
Yeah,
adults,
either or. Yeah.
first line therapy is CPAP because it's non-invasive, a lot of data behind it, and that's really great if you can use it. Half of people use it, half don't use it long term, and that's my whole be- being, frankly, is people helping people that can't use CPAP and looking for other options.
Gotcha. Okay. So what other let's talk about compliance actually. Let's just
Yeah.
drive back to that. So I know a lot of patients that I've talked to and be like, hey, was your CPAP? They're like, I haven't worn that in like 5-10 years. I'm okay without it. So are there alternatives to somebody who doesn't want to wear a CPAP?
Yeah, and again, I run and founded the CPAP Alternatives Clinic here at Penn in Philadelphia, and this is designed for people that are like that. It's they come in and they're told you got to use CPAP, and they try and they try, and then the doctor says, well, you failed. I mean, you're a failure of CPAP, and that's so you said it's been in the closet for 5-10 years, and they're told that's all you have, and then they come and they see us, and they realize there's often other options. And when I say often, if the patient is morbidly obese, there's often not much I can do because often the obesity is driving a lot of the sleep apnea. But if they're not, a lot of our patients are not obese with sleep apnea, then we look at other options, and that starts with things like weight loss, of course, but then even something called a mouth appliance that moves your lower jaw forward while you sleep. You may have heard of those. They're basically made by dentists. They pull the lower jaw, they stabilize it forward, and that kind of opens the airway, and that can work for maybe half of our patients that come see us. Some people, about half of people are with mild sleep apnea are just on their back. So you may have heard of the old tennis ball in the back of the shirt thing. I mean, there's ways to keep you off
Hmm.
your back. That's called positional therapy, to get people on, and
Okay.
you'll hear the bed partner, the wife will say, you know what, I give him an elbow and then he's fine because she put elbows him in the rib and then he turns over and then he stops snoring and then he comes back and she elbows him in. So that idea of like turning over, it's gravity, right? If you're on your back, your tongue and your palate are going to go back, and if you're on your side, it falls to the side. So that's effective for some patients. And then, again, really what I spend my time is talking about surgical options, especially in young patients, who don't want to be who don't want to be wedded to a machine the rest of their life. Is there something else, doc, you can do? And often, if they're the right candidate, we do a full work. It's quite a workup, but figure out, what is the offending agent? What is the problem? Is it your tonsils? Is it your jaws? Is it your soft palate? Is it your tongue? What's causing this anatomic issue? And from there, we can start to talk about different classes of surgical treatments to help them.
Gotcha. Okay. What about like mouth taping, right? That's something that I know a lot of the functional medicine doctors out there talking about, a lot of the breath work gurus.
Mhm.
Is that something that can prevent sleep apnea at least? Because I mean, it sounds like if you already have it, that might just actually worsen it.
Yeah, it's mouth tape works well in a very small group of patients that I have. So, like a lot of things, Dersh, I mean, there are treatments at work that are the indications are obviously much too broad in lay terms. And in books like Breath, while they raise awareness, they also sort of make people think, oh, I can just do this and I'll be better. Well, no, usually
Right.
that's not it. So mouth tape works well in patients in my mind who have usually snoring or mild sleep apnea, and the issue is their mouth opens during sleep. And so when you apply a piece of mouth tape across the lip, you force nasal breathing. And nasal breathing is essential to normal sleep breathing. In other words, if you're a mouth breather, in my mind, you're pathologically breathing at night because the mouth is meant for eating, not for breathing. And the nose has a very nice pathway around the back of the throat to the trachea to the lungs, and you can create this nice laminar airflow. And if your mouth is open, it's a very turbulent path to get there. That creates snoring typically, and you lose some of the benefits that have been reported about nitric oxide and other things that you want to get as the air is filtered, warmed, humidified by your nose. You don't get those benefits by intaking through your mouth. So from that standpoint, mouth tape can be helpful. Um, but again, that's really a subset of patients. Again, in my practice, are coming for sleep apnea. Maybe more common there's in lay people who have a little bit of snoring and that kind of thing.
Yeah, sure thing, sure thing. I do want to quickly touch on pediatric patients at least because, obesity rates are at 38%. They're only climbing. We're seeing it so much in our young population, which of course, could be contributing a little bit at least to sleep apnea. What do you tell parents to watch out for? Because I'm sure a lot of these teenagers aren't gonna, or if is that the common age at least that we're looking at with sleep apnea in
And
the younger population? Is it like
you know,
teenagers?
in kids, school age kids, and that's because of tonsil overgrowth. Tonsils get big. About 6 years old. 8 years old, and they get bigger a little bit earlier than that. And you talk about and then the kids. It's interesting. There's the kids. I told you about sleepiness, irritability in adults. As the kids. Can I ask you a question? What do you think the kids'
Hmm.
hallmark symptom is of sleep apnea behaviorally?
Tired? I'm guessing like just out of it.
And that's what you
Not
think.
doing well in school.
So
I don't know.
but that's right. Not doing well in school, but not because they're tired, because they're hyperactive. So,
Okay.
so, so children have the opposite response. They're actually not. They manifest tiredness, which maybe that's correct, but they manifest it as being hyperactive. And so it's
Uh,
amazing what parents will say after you treat the sleep apnea. Like, wow, I thought he had ADHD, but actually he was just sleeping poorly, and it can be really profound. I mean, right after the surgery, the kids are able to listen. I mean, it's so, yeah, I don't treat kids regularly. So, what as a
sure.
trainee, I did a lot of that, and I still think about the examples are pretty dramatic, and again, it's a very different expression of that, in the way the kids are. The hyperactive kids with big tonsils, that's the kid that needs the sleep apnea.
It's funny you mentioned that. I'll never forget now. Actually, going back to my peds rotation, my third year of med school, I worked with a phenomenal pediatrician who had a very integrative, like functional mindset as well. And so, when patients would come and be like, "I believe my kid has ADHD. I got the paperwork. This is what the teachers are saying." First thing he'd always ask is, "How are they sleeping?"
Hmm.
So, yep, that
Yeah,
makes a
because
lot of sense now.
there's if you have a kid that's snoring and that's hyperactive, I mean, the first thought would be ENT evaluation for tonsillectomy. Yeah.
Right. Right. Cool. Okay. Awesome. Anything else you want to talk about in terms of sleep apnea before we kind of move on to talking about research? Is there
Mm.
anything you wish more people understood about sleep apnea in the medical field, patients, parents?
I think we covered a lot of it, Dersh. I think again, maybe this is a little shameless plug here, but I mean, there are options that are not CPAP. And one of the cool ones that's come out that it's been a lot of marketing, but it's actually been very helpful. Something called Inspire, which is a device we implant. It's basically a tongue stimulator we implant. So it's like a pacemaker for the tongue. And this has been a really good option for people that are, especially older patients with sleep apnea, that it's a relatively non-invasive procedure. And it really helps with sleep apnea. And patients find it very comfortable, and it's a remote control. You just, turn it on, go to sleep, and wake up. In the right patient, just like mouth taping, it works really well. And so we spend a lot of time, understanding who those patients are. But these patients are very grateful. They say, "Man, I thought there was nothing else I can do about it, but boy, I like
Mhm.
this. I liked it. I hated my CPAP, and actually, I like this thing. So that's nice to hear that there are things that are palatable to patients with technology.
Perfect. Yeah, we'll link that into the show notes. So I'll talk to you afterwards, and I'll get whatever links you suggest, and we'll
Oh,
put in
sure.
the show notes for people to click on. Perfect. All right, so let's get into your current practice, because when people think physician, they think they're seeing patients 24/7, and that's not necessarily what you're doing on the week to week. So break down kind of what you're doing from a Monday to Friday standpoint.
Yeah. I'll start by saying I have the best job in the world. I mean it. I mean, you couldn't. I wouldn't do it any other way. And it's not by happenstance. This has sort of been curated over the last 12 years of my life. But it started with understanding that what there's more to medicine than clinical care, as you just said. And to me, like one of the challenges as I was going through medical school and residency was like, I don't want to be a cookbook clinician. I don't want to read the latest algorithm from this journal and then just do that. I want to help actually design the algorithms. I want to be use them to create my creativity a little bit. And so what I realized was research allows me to be creative. We all have different avenues. I know Dirk, you do, and others do, and how to use that. This podcast, to me, is an example of your ability to be creative outside of your residency. So, how do you do things that are expression of yourself, but actually allow you to be creative? So to me, with research, designing a clinical trial, I really enjoy that. And I have a master's in that I can talk about. But I thought there's something else that I could do that's not that. So that's sort of that's the backdrop. Now, let me answer your question. So Mondays today, I work from home, right? So I'm a surgeon that works from home on Mondays, and that's to me wonderful. I get to do things that matter to me, like take my kids to school this morning, see my personal trainer, and I have 8 hours of meetings in between. So I'm doing research, reading sleep studies, preparing notes, doing high level things, but I'm able to do it from my own home. And I think for those that are younger, your audience, and thinking about work life balance, Dirk, we and I have talked about this for a long time. This is important. This is how I'm going to do this for the next till I'm 80 years old. I think. I mean, I really feel I don't feel burned out. I feel like I have a good balance, and so the research day gives variety. So this is I'm home on Mondays doing research primarily. Tuesdays, tomorrow I have a full day clinic. It's full day clinic, and I derive a lot of energy from clinic. Seeing patients, and hopefully like you feel the same way. We give a lot. I mean, every time you got to meet a new patient, it's like interviewing somebody as we're doing now. It's sort of it's exhausting, but at the end of the day, you realize when you help patients, how rewarding it is. So, and that's where the questions develop, right? Clinic is where the research questions are born because you have a patient that comes back from a procedure. Let's say you did some whatever procedure you did. This is for any clinician. You do a treatment, you come back, and they're not better. And you go, shit, what do you mean? What do you mean you're not better? Of course you're better, right? This is the right. I gave you my treatment. No, and then you look at the test, and they're not better. The sleep test didn't change at all. They don't feel any different. And you ask yourself, what did I miss? And the failures are what teach you the most, right? Successes, you say, yeah, okay, I knew that,
Right.
or sort of, you pat yourself on the back and go to the next patient, right? But the ones that really, hit you from the front, like, oh my gosh, I didn't, I was blindsided by that result. And then I make a note and I go back to the lab on Wednesdays, one of my, or Thursday, my research day, and I go to we have a group of now 10 of us in my lab, and I say, I had this patient yesterday or on Tuesday, and I did this, and I don't know what happened. And we have developed for each patient streams and streams of data from their sleep study, from their CAT scan, from their sleep endoscopy, from their surgery to help understand what happened. And that to me is really powerful because we have that ability. Um, so sorry. So that's Tuesday's my clinic day. Wednesday I usually operate, and that's doing procedures from endoscopies to jaw surgery, really the gamut of minimally invasive to more invasive surgeries for sleep apnea. Thursday again is my lab meeting, and we get together as a group to talk about it. And Friday, it's either research or it's more surgery. So it's a balance of clinic, of procedures, of reading sleep studies, of doing research. And I think for anybody that's an aspiring physician, thinking about how can you keep your life interesting on the daily basis, right? I mean, we're used to 4 years of college, 4 years of medical school, 4 years of residency, 4 years of 40 years of attending hood, like four, and then
Yeah.
welcome to like 40. It's like, oh, okay.
Right.
What do I do after 4 years? Like, you know, I mean, you're probably gonna get sick of it, and frankly, a bit burned out unless you have the ability to mix it up. And in my case, I treat the individual patient, and then I'm treating the next generation of patients with my research. And so I've got that, ability to feel like not just what's in front of me, but it's what's beyond me that I'm going to influence. Oh, and by the way, I have two fellows that I train every year and a cadre of residents. And so I also have the ability that I'm really training the next generation in my midst. So it's like, yeah, so I mean, I preface this by saying I have the best job in the world because it's super fulfilling. I have a pretty good work-life balance, and I get paid pretty well. So it's really, I really think I found it, and hopefully I'll, hang on to this. Yeah.
I love it, man. I think it all starts with something you mentioned earlier, right before saying all this. It comes down to creating value, right? Like where can you create the most value that you can every day, right? And everything else kind of just falls in place. The fact that you like to teach, the fact that you realized you liked research, right? I mean, you tried it, you got a master's in it. If you didn't like it, great. That's more information for you to say, hey, I'm not going to incorporate this into my attendingship. But you like that. You like the flexibility of the work-life balance, spending time with your kids. You're a family man. You also like the fact that you're doing different things every day, right? But it all surrounds around creating value, right? So I'm a huge fan of that. I always talk about that. It's the reason why I chose PM&R is like I saw this need in exercise physiology and functional integrative medicine, and I thought if I just create value every day, things are going to fall in place. So I just think that's great advice, at least for pre-meds and med students who are looking to go, slowly go into residency and attending ship, but are hearing so much about burnout and the
Hmm.
what are they calling it right now? The Great Resignation with COVID, and how many people are leaving medicine because of COVID, and just wanting work-life balance. So it is possible, even from a surgeon. So it's definitely possible out there.
Yeah, I mean, I like that, Dirk. I mean, yeah, creating value, and because I think that gives you energy. You feel like you
Yeah,
are creating value, and that honestly gets me up in the morning. And
yeah.
I get up in the morning, and I really, in the end of the day, I treat one disease, but I look at it as in the clinic, in surgery, reading sleep studies, and doing research. So you're able to take one, think of the spectrum of medicine. I'm talking about obstructive sleep apnea, which is a little piece of the pie, right? But you're able to look at that and look at it from all angles, and every angle teaches you something else. And I think that's,
Yeah.
yeah. I mean, the best advice I got. I think I was a medical student at Northwestern, and somebody said to me, Raj, choose a field where every patient seems different to you. In other words, this is like the podiatrist finds every foot to be different and interesting to them. God bless them.
Yeah.
So like to me, every airway is unique. And when I do a scope exam or look at the patient and I go, yeah, I'm not sure what it is about you, but I'm going to figure it out, and that keeps me going. So I think if you're again pre-med thinking about what to do, think about that idea because look, let's call it the surgery may be gone in 5 years. Well, if you chose something based because you like this surgery, in my mind that's bad. That's a bad decision. Choose it based on the disease process that captivates you, and from there you move with it, right? You got to adapt to what's going on, and so you never lose interest or focus on what you're doing.
And I think the other thing you were kind of just talking about there is you create the breadth while you focus on the depth, right? Like you're just
Mm.
focused on sleep apnea, but because of it, there's so much other that you're learning and understanding, right? We talk about the downstream effects. You talk about different patients going through different things. So, yeah, it's that's definitely really good advice. I'm going to steal that as I coach some more pre med. So
None of this is
like that.
patented, so it's all you can take
That's
whatever you
right.
want. So,
Like it. So speaking about, pre-meds, I've done a lot of coaching. And one of the most common questions I get is, hey, Dr. Darsh, I'm very interested in research. Is it worth doing an MD, PhD? Now, from your experience, you've done a master's in clinical research, and I mean, you're very research heavy. I'm on Doximity, and I keep seeing Raj Dedhia this, Raj Dedhia that, right? You're pumping out papers, you're pumping out studies. What is your advice in terms of at least the difference between doing like a master's in clinical research versus going down the route of an MD, PhD?
Yeah, let me start by, I think a really common thing I hear from medical students that's if they divulge to me, their deepest, darkest thoughts, it's usually something about, I know ENT is competitive. I have to do research to get in. So it's
Hmm.
a means to an end, which I think a lot of people are exposed to research in that way, which I think is a problem. It's like
It is.
it's another
Yeah.
stepping stone to like getting into something. And actually that's how it was for me. It was like, oh, I'm like, applying to this. So I did the research and, I can talk about it on the interview trail and I can flash through publications on PubMed to them and they'll be all be impressed. But like at the end of the day, that's actually not what it's about. And I think when
Right.
people see that, hey, you know what, this research that you're doing is, I mean, we have been changing the field over the last couple of years of sleep apnea surgery with the work that we're doing. I mean, it's really revolutionizing how we're practicing. I want to say across the world recently now, because we understand these measures. And that's really exhilarating that our team is developing techniques and understanding, because I think and it's hard, Dersh, as a medical student, you're not in a situation where you've been in practice for 5 years, you don't like your outcomes, and now you want to do something about it, but you can't do anything about it. You're not trained in research, you don't have research time. And so it's like, okay, well, I don't know. Now what do I do? So, but when you're a clinician and you're in that situation, you wish you had the tools to actually act on your disappointments or things you want to change. But I
Hmm.
struggle with this. Maybe you can help me. Is, if you're a pre-medical student, and you're coming into it thinking like, hey, I got to do research because I want to do, maybe they're asking you like, should I do it? And like, what, like, is it number of papers? Like, basically you want to get published, and publications, as it goes on the CV, and that might lead you to opening doors. Um, but what I hate about that is that often that's, to pump out papers. I've used a term, in a pejorative way. Pump out
Yeah.
papers is really a term that I hate, because it's sort of saying like, I want to get things out there. I want to do that, and somehow that's the end goal, is to publish a paper. The end goal is actually to
Right.
change patient care. You know, that's
Yeah.
really what we're doing. It's not to write another paper, another Me Too paper that nobody's going to read, that will go whatever, that has shoddy methodology. That's not helpful to us. But it's hard because like real science takes time. It takes a well-designed study. It takes somebody that knows what they're doing. It takes resources. Like, I'm lucky to have funding from the NIH and several industries. I mean, we have funding to do these projects, but if you don't have funding, it's hard. It's hard because you have to have expertise and resources to get it done. So I think this is the challenge to me, is that you have to be able to, as a medical student, appreciate or to be inspired that research is not just a means to an end, but it's a way of life to help
Yeah.
patients down the road. And this is hard, man. I don't, and I know, because I know this, because the admissions committee for residency or whatever is going to look at your CV, look at your publication list, and is going to be impressed or not impressed based on how many publications you have as first author, let's say. But it doesn't really just, I mean, I've interviewed many people, from medical students to residents to fellows, and I realized some of them know a lot about research and what they wrote, and some have actually know very little. I mean, they know they published something, but they couldn't tell me about a sample size, or how, they couldn't defend the research. And that's, to me, I'd rather, one paper, and show me that you know what this means and how it changed behavior. But that's not, this is a deliverable oriented society, especially when it comes to this kind of stuff, right there. So I mean, yeah, I'm putting it back to you. I mean, is there a way to sort of help people understand that it's not just a means to an end?
Yeah, no, I mean, I totally agree. So my intern year, me and my co-residents always talked about this, right? Like, the only thing we found meaningful in terms of research were like quality improvement projects, right? QI projects, because there was some resident benefit usually to it. And we're saying,
Hmm.
hey, how can we improve resident life? And
Yeah.
then we were so invested into it, right? Because wow, we're actually changing a system, and there's
Hmm.
before and after, and the projects weren't taking so long. But when we talked about, how do we hop onto a project, right? Everyone talks about, hey, can I hop onto a
Hmm.
project?
Right.
You're hopping on for what, right? Are you actually interested in this subject? Sure, you might be, but is it the role you want, right? And I'll never forget, I mean, talking to you, early back when I was undergrad and trying to get into when I was at Penn doing my cancer rehab
Hmm.
research, you always talked about, hey, there's three things like you kind of want to do. I might be forgetting something, but one's like trying to understand scientific writing. Two is like actually getting involved with the patients, right? Actually getting involved with the systems, trying to figure out from top to bottom where is it that we need the most help. And then a third, I think you said was like, well, I talked about medical writing. I think it was more just understanding the topic as a whole and presenting that, right?
Right.
A
Good
lot of
memory,
times,
buddy.
like even, yeah, yeah. I don't forget your lessons, man. um, but a lot of the times, like even at my residency, a lot of it is just, okay, what's the timeline? How do we get you to present something, right?
Hmm.
And
Yeah.
something doesn't necessarily equate to good or great, but great and good also doesn't have to be the answer, right? It has to be
Hmm.
something that you actually enjoy to say, hey, I'm interested in this. Let me do a lit review. And I think that's the first step. Like, if you're not interested in doing a lit review on the topic, you probably shouldn't be doing that research. Because, I mean,
Right.
there's a lot of articles to go through. A lot of it can be boring, a lot of it's numbers, but a lot of it's just delving in and doing the deep work and being like, I'm going to sit here, I'm going to challenge myself, and I'm going to have to use YouTube and other videos to learn stats and other things to make sense of this. So it's tough, I'd say,
Hmm.
as a pre med because I don't know if you heard about this. They're calling it the Fauci effect now in terms of the number of applications for medical school. So
Hmm.
ever since
No.
COVID happened, the number of medical schools have skyrocketed. They're calling it the Fauci effect. But what people aren't realizing is it's not because of Fauci; it's because it's virtual. So you don't have to spend as much
Hmm.
money to like go around, and people aren't taking the MCAT. Anyways,
Hmm.
I'm talking on a different end there.
Yeah.
I don't, just to be competitive now, it seems like you have to have research. And I totally get that. So sometimes, like you said, it is a means to an end. But in regards to an MD, PhD, and, something like you did, whereas a master's, or not even doing a master's, I don't think you necessarily need to have that PhD to look competitive or do research, right? And I think you're a prime example of that. I think the skills that you have as a researcher are just as equivalent as somebody who goes through their PhD, possibly, right? Like, would you say that's wrong? I mean, I think
Well, yeah. So it
it's
right.
self earned, right?
It's sort of. I think one of the things you have to think. You have to sort of. We have to just separate is clinical versus basic science. I'm a clinical translational scientist. I am not a basic scientist. I don't want to be a basic scientist. I never wanted to be a basic scientist. I don't want to be in a lab doing stuff to animals. So, I think, if your interest is basic science related, typically a PhD is a natural progression, a natural home for that because of the rigor and the time it takes to run an experiment. And you get mentorship along the way on how to do probably basic science research. Now, there are more clinical translational PhD things that are happening, whether biostats or some of the big data stuff that you can do, but that's still a less well-trodden path. And for me, my interest was really more clinical. So the Master's of Science in Clinical Research to me makes a lot of sense. It's 1 year. You get to learn, the applications and how to conduct clinical research in the setting of patient care. So I think that is a really nice thing. But yeah, the MD PhD, I mean, that's 5 extra years or 4 extra years of your life. I mean, it's a huge commitment, right, Dersh? I mean, I wouldn't do it unless I was really passionate about it. I mean, there's a monetary savings perhaps, but maybe not in the long term, but in the short term there is. So I think you can imagine that if you're serious about it, okay. But again, this is what I'm saying. It's like, are you doing it just to do it, or do you really
Right.
get excited about that kind of stuff? So
Yeah.
yeah.
Yeah, no, and I know a lot of people are doing it because of prestige. I mean, you're
Hmm.
18, you're what, 17, 18 years old. And I talk about this all the time as a pre-med. You have no idea what your life's going to be at 30, 31, 32, right? And we're
Yeah.
forced to make a decision so early on to say, hey, this is what you're going to be doing for the rest of your life. And, that's obviously a reason why burnout rates can be very high. And I think one of the things, again, as you've done, is adjust to that, right? As you keep getting older, constantly changing your
Hmm.
values, right? Every year, just saying, hey, what do I value? What do I want to do? And kind of playing that game. But yeah, I think it's a sad state that we're in for research right now, at least in terms of the medical school residency level, because I just don't see a lot of people going into it unless they're
Hmm.
kind of forced to do it and then haphazardly being like, oh wow, I fell into something I like, right?
Right.
Um,
Right.
but I guess yeah, go ahead.
No, I mean, I think that's, one of my goals. We have a medical student now from Temple who's with us for a year, and the goal is, I mean, he's coming wants to do going to ENT residency and to get experience. And but really, my hidden, well, I guess not anymore. My hidden goal is to inspire him to become a certain scientist down the road, right? To say, hey, yeah, this I thought this was a means to an end, but actually this is really invigorating. This is intellectually very stimulating, and I miss this as being a trainee, and I see a future in this, down the road. So I think in some ways, leading by example, and people see my genuine excitement for research, and hopefully that triggers others.
I know one of the things you've always told me too is like it's not always about publishing about that headline, right? That thing that catches the conference title. It's also about publishing things that didn't work, right? And I think that's
Mhm.
important. So we're not wasting years and years of just duplicating research, and that's why it's taken 10, 20 years down the road. And I mean, I know internationally right now we're definitely having an issue of actually peer reviewed looking at it instead of falsifying data, right? We start with Andrew Wakefield, right, about
Hmm.
MMR, vaccines, autism, the gut microbiome, and now ivermectin. That was a whole thing during COVID, falsifying data, and now even COVID itself in terms of reducing transmission, right? The Pfizer executive came out and said, "Oh, we actually never even tested transmission." So there's a lot of just like mistrust going on, and
Yeah.
there's no real police out there. There's no real police that's able to go to these researchers, hunt them down, find them, and say, "Hey, what did the data actually show?"
No,
So it's almost like,
yeah.
what do you believe? What do you not believe?
Yeah,
It's
no,
pretty tough.
you're right, man. I think that cynicism is what I remember feeling that way early on. I was like, this is garbage. I
Hmm.
mean, I could make this Excel cell say 1 or 5. I mean, the power was in my keystroke. You know what I mean? And you realize, and that's all, and that's the primary data. So like, if I didn't select this cell because I forgot, inadvertently or maybe on purpose, I changed the whole meaning of and it's like, wait, I'm the one that's responsible for this. Like, where's the data monitoring board? There is not one. It's just me. And so, and the same thing, like you said, is that it's so easy. And so, yeah, I mean, I get it, Dersh. I mean, that there's rightful cynicism about this stuff, and I don't know a way to correct it. And, peer review is peer review. It's not like some objective, measure. It's like, okay, if I know this guy and I review it and I trust him, I'm going to trust his work. I mean, it is right. It's a lot of that's reputation and how things go for grants and papers, and so you hope that somebody's not built at a house of cards. They actually have done work properly, and you can, and ideally you do validate data. People don't like to do that, but that's an important part of the scientific community. Is you got to validate what that landmark paper just showed, and if you can't, then there's a problem. So, but in COVID, and we're searching for cures. I mean, nobody has time to think to do that, right? Or the resources to do that. Maybe let's say for can't run another Pfizer trial, and that takes forever. So you're right. So then you really are relying on the initial investigators to be truthful.
And so, like a couple people that I've really enjoyed listening to, Peter Attia, Lane Norton, for those that are very interested in the lifestyle and medicine aspect of this podcast. They're two researchers or two scientists at least that do a lot of research, go into statistics, and teach you how to read papers,
Mm.
right? So I think there's also that gap where how do you read a paper, So those are two resources. Then examine.com is also another one that I highly recommend for the listeners out there in regards to trying to learn how to read a paper and extract value out of it.
You're exactly right, Dersh. And a lot of we have a resident program now that I'm helping to not just I call it sort of two modes of research. There's research consumption and research production. Not everybody's going to come out and produce research, right? But we all should be able to consume research in a way that, okay, like you said, maybe these resources that help you consume research in an educated fashion to make your own, conclusions, but really understand the methods of the paper. So I think you're right. Research consumption is a must for any clinician.
Yeah, it's funny. I mean, during COVID, a lot of people are like, "Oh, you got to do your own research. You got like, what does that mean? We haven't even taught the public how to
Right,
how to
right,
read what an abstract is or what like a ANOVA is, right? Like, what's a
right.
p-value? Like,
Yeah,
how are you going to tell
no.
people to do their own research when they don't know the methods behind
Well,
it? I mean, sure, you got, yeah, go ahead.
no, and I think you're right. And another piece that's really hard is, often you have a paper that has a conclusion, but it's not generalizable to you, right? So like, okay, in this population, this happened, but it's really difficult to say, okay, to you or the patient in front of you, does this apply? Um, it's like this gets a little bit nihilistic, but you think about like Tylenol works in like two-thirds of people or something like that. So third people, Tylenol doesn't do anything. So is it effective? I mean, I don't know. It depends. It's effective in you, but not me. But okay, but Tylenol's Tylenol, man. Nobody argues with Tylenol, right? Or you name the medication or the intervention, and it works in a subset of patients, but not others. But so how do you apply that data to? And this is where it gets really difficult with even reading a paper and applying the data. So I don't does it apply to my patients? I don't know. Yeah, this no, this I mean, I'm getting in the weeds a little bit, but I mean, this is like things that we just think about it is, how do we take this stuff and actually apply it? It's not easy.
Very important stuff. So definitely, dude. So what is next for you? I hate to ask what's next in the next 5 years, but what are you thinking? The next months, next year, in terms of your research, in terms of your life.
Yeah, I mean, it's professionally, I think we're growing a lot. So again, I'm at University of Pennsylvania in Philadelphia, and we developed a division of sleep surgery, and we've been here for it's over 3 years now, and it's grown exponentially. And to me, it's interesting. Like it really comes back there's to tomorrow's clinic, Tuesday clinics, and what drive home, and I'm in my mind, there's usually a couple thoughts in my head as I drive home. I think usually about a patient or two that I saw that day, new patient or patient I've operated on it, and I think I don't understand this, and I write those down, and then it becomes a common theme about what I don't understand, and that becomes sort of what I want to study the next that's the next grant application to the NIH, and so it's just a matter of as we start to stomp out these fires in our field more, we're aware of more and more come up, and it's sort of just, there's a logical progression here, but I think to me, it's sort of, that's how it goes, that, what is the greatest need? We're addressing that now, and hopefully the needs become smaller, and we can start to just march our way down and getting more understanding of that. So, I mean, that's sort of a long answer to your questions. I think it just,
Love that.
it comes from what we see in front of us with our patients. And look,
One patient at a time.
one patient at a time, and you got to be honest with yourself, and you got to be honest. It hurts. I mean, literally, a little piece of me dies when I have a surgical failure. I mean, I'm literally like, my some patients are literally consoling me because they can see the look on my face like, Dr. Dedhia, it's okay. And I'm like, no, it's not okay because I didn't yeah, he's like, I'm like, give me the tissues for me, I'm like, I'm like in tears because I'm like, I didn't expect this. It's driving me freaking bananas. But that's what I use. And so I think like I hope that doesn't die there in me, that I don't feel callous to these events because it happens. You just me long enough. Yeah, okay, it happens. Yeah, yeah. Like, no, I don't know why it
Yeah.
happened, and I have to. That has to be there. And I think to sort of to say this a little bit more generally, the minute you stop giving a crap, as a doctor, go do something else. And that might happen to me. It might happen to some. It happens to people all the time. And it's true. I mean, go do something else. It's not fair to your patients. It's not fair to you to do that. So my part of my whole sphere in developing my unique variable variety is to never get to that point, right? And so we'll do a podcast in 10 years when you're somewhere and doing some great things,
Love
and
it.
maybe
Yeah.
I'll be interviewing you at that point in my own podcast because I'm bored of medicine and want to do something else. But it's
That's right.
yeah, so I think that's sort of just keep doing what I'm doing. I think there's a lot of things I really feel like we've just built the infrastructure here at Penn to really answer questions, and that's really invigorating. It takes a while to develop infrastructure for research. It's not an overnight thing, and I think once we're at that point now, it really becomes fun to start answering questions. And there are a lot of them.
Very cool, man. Well, hey, you've got a curious mindset, so I don't really see that flame dying
Hope
inside of
not.
you, man. One patient at a time seems like you got it under control, and you're trying to learn something new. So love
Yeah.
that. I think the listeners can take away something from that as well, and learn a lot. So speaking of the listeners trying to find you, where can they go if they want your assistance?
Well, my assistance is a little scarce at the moment. My practice is fairly niche. In other words, people that see me have to have had a sleep study and had to have tried and failed CPAP. And if they meet
Okay.
those two criteria, they can certainly schedule with me. Easiest way is just go on the Penn Medicine website and find me, or maybe I can send you some email there with the direct, even
Yeah.
like my schedule or that kind of stuff if they're interested in that kind of thing.
For sure, definitely. Yeah, we'll put sleep apnea research or sleep apnea links up in the show notes as well, just so people can get some more education on that as well. Awesome. Hey, man, last question we ask everyone is how do we put the health back in healthcare?
Health back in healthcare. It's something that I told you about long ago. I was on this path of integrative medicine at Northwestern, and I really felt that what you're doing now is what I thought I'd be doing 15 years ago. I would be doing Andrew Weil Integrative Medicine Fellowship after medicine, and then doing functional. We didn't call it functional medicine then; sort of integrated medicine, I think, was the term that we
Yeah.
were using back in 2006. And that was about putting the wellness, the health back in healthcare. And now I'm a surgeon. So, the challenge with what I do is that I'm really I am at the end of the line when disease has progressed so much, right? That we missed it. And actually, what I do now, telling a lot of my patients who have young kids, is to see ENT and orthodontists who can help expand the jaws to hopefully prevent what's happened to them, to the parents. So it's kind of cool in my world is that I can try in the next generation because most of my patients are older with children, some of them young children, is what can they do at that age? And most of that is really jaw development because they often inherit their parents' small jaws to try to help educate them about there's things that you can do at an early age of 5, even with expansion of the upper jaw to help that. So maybe that's in my little world what I do to try to put the health back in healthcare is that I want to be out of business in 20 years. I really do. I don't want to do any more surgeries on people's jaws and then because I want people to have, fix that or address that back in their school age. So that would be my goal, and it's a matter of educating people and the books that come out like Breath and you reference others that are helping understand that we are devolving as a human species, and the things we can do to hopefully alter that trajectory at a young age while we're still, somewhat supple and able to be modified. That's what we got to do.
I think this entire episode, I've been clenching my jaw, putting my tongue to the roof of the mouth, and just mewing. So,
Viewing, yes,
trying to
right.
expand
That's
that
good.
mouth. Yeah.
Very good, man. John, you'll be
Well,
proud,
yeah,
man.
yeah.
John, you'll be
That's
proud.
right. That's right. Well, hey, Raj, appreciate it, man. I think this is such a valuable show that we're doing for the listeners. We touch on sleep a lot, but we've never really touched on sleep apnea, which I know is affecting so many people out there across the world. And so what you're doing is spreading the good word. So appreciate you coming on, man. Thank you.
Actually, you're spreading the good word by this podcast, so thank you.
You got it, man. Thanks.
Okay, good night.
Well, there you have it, everyone. That is a deep dive into sleep apnea. I'm grateful that we were able to bring on Dr. Dedhia. His way of explaining things just makes so much sense, not only to clinicians, but also to patients. And it's amazing to see that the research he's doing, being one of the leaders in sleep apnea research and just really changing the game and changing the field. I'm excited to see what else he can do in the next 5 to 10 years and how sleep apnea research and awareness will constantly be changing. If you know anyone with sleep apnea or anyone with sleeping issues, please send them this episode. As you heard, sleep apnea is becoming more and more prevalent, and we need to do our job in terms of spreading the good word, spreading medical education out there, and getting this episode into the hands of people who really need it. And be sure to check us out on social media. If you want to hear the funny snores and noises that Dr. Dedhia was making, I'll be sure to put those up on our Instagram, TikTok, Twitter, and of course, my LinkedIn. And of course, the medical disclaimer, everything in this podcast is for educational purpose only. It does not constitute the practice of medicine, and we are not providing medical advice. No physician-patient relationship is formed. Anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. As always, if you have any questions, if you have any videos that you want us to check out, and any myths you want us to bust, please send them our way at medredefined@gmail.com. See you later.